Welcome to PFT Tutor with Jeffrey Haynes. In this video, we'll review a case of an asymptomatic patient who appears to have obstructed airways, or maybe not. This patient is a 25-year-old male. He complains of vague chest discomfort, but denies any chest tightness or wheezing. He's never smoked cigarettes. He does not have asthma or atopy. He was prescribed albuterol, but it doesn't relieve his symptoms. Here is the baseline spirometry. The forced vital capacity is pretty large, almost above the upper limit of normal with a z-score of 1.60. His FEV1 is above average with a z-score of 0.17. However, the FEV1 to FVC ratio is below the lower limit of normal with a z-score more negative than minus 1.64. So maybe this patient does have asthma. The next test I performed with oscillometry to assess airway resistance. This green line represents the airway resistance at different frequencies. R5 is the resistance at 5 Hz, and that represents the total resistance from the mouth down to the small airways, and it is very normal, below the upper limit of normal. R20 is the resistance at 20 Hz, and that represents the larger airways, and that's also well below the upper limit of normal. If you subtract the large airways from the total resistance, you can theoretically isolate the small airways, and that is the value called R5 minus 20, which as you can see here is quite normal. If it wasn't normal, the green line here would rise as the frequency decreased. This is called the frequency dependence of resistance and may represent small airways disease. On the oscillogram, there's a second green line indicated by the red arrow, and where this extends below 0 is known as the reactance or compliance of the respiratory system. One of the key reactance measurements is X5, or the reactance at 5 Hz. If the patient had reduced compliance from thick, stiff airways, air trapping, or parenchymal or chest wall stiffness, the X5 would be more negative, below the lower limit of normal. The point where the reactance line crosses 0 is known as the resonant frequency. The area highlighted in blue from X5 to the resonant frequency is known as the area under the reactance curve. The smaller, the better. If the reactance were abnormal, the area under the reactance curve would be larger, as shown here. In this case, the reactance at 5 Hz and the area under the reactance curve are quite normal. So why does this patient have mild obstruction on spirometry when they have normal airway resistance and reactance on oscillometry? Odd. The next test that was ordered was DLCO, and this showed a value above the upper limit of normal, and this was due primarily because of a high alveolar volume of 8.28 liters with a z-score of plus 2.29. This patient has large lungs. So this is when I start to understand what may be responsible for the patient having a low FEV1 to FVC ratio. I suspect this patient has a low FEV1 to FVC ratio because of dysanapsis. What is dysanapsis, you may be asking? Well, dysanapsis is when the size of the tracheobronchial tree and the lungs are out of proportion. The graphic at the top of the screen depicts both airways and lung that are normal size and are proportional to each other. One form of dysanapsis is normal-sized lungs but relatively small airways, as shown on the left. Another form of dysanapsis is decreased airway size coupled with large lungs, as shown on the right. And the third variation of dysanapsis is normal-sized airways with large lungs. This is what I suspect the patient here may have because the alveolar volume from DLCO is elevated and the airway resistance is normal. So if you have this type of dysanapsis, it's just going to take you longer to exhale your lung volume through normal-sized airways, giving the appearance of airflow obstruction. Let me make a case for my theory. This is a study that was published in the Journal of Applied Physiology where they measured dysanapsis with CT and tried to see if spirometry could identify the dysanapsis. There are a couple of ways to measure dysanapsis on CT. You can measure 4 large airways shown in red. You can measure 10 airways as shown in yellow, or you can use all 14 measurements. The airway size is divided by the lung size, and this gives you the airway to lung size ratio, or ALR. The smaller the ALR, the more dysanapsis is present. They divided the airway to lung size ratio into quartiles. The lowest quartile had the most dysanapsis, and the highest quartile had the least amount of dysanapsis. When you compare the FEF 25/75 to FVC ratio and the airway lung size ratio, you can see that the value is lowest when there is the most dysynapsis. The patient in this case had an FEF 2575 of 3.72 liters per second. If we divide that by the FVC of 6.57, we get an FEF 2575 to FVC ratio of 0.57. And when we place this value on the y-axis as shown by the red circle, it supports the presence of dysynapsis. You can also use the peak flow to FVC ratio to try to identify dysynapsis. The lowest airway to lung size ratio also has the lowest peak flow to FVC ratio. The patient in this case had a peak flow of 10.79 liters a second. If we divide the peak flow by the FVC of 6.57 liters, we get a peak flow to FVC ratio of 1.64. And when we place this on the y-axis as depicted by the red circle, it is clear that the peak flow to FVC ratio also supports the presence of dysynapsis in this case. So I've presented dysynapsis as sort of a normal variant airway to lung size, but is it purely a normal variant? Actually, the answer is no. This is a study from the Canadian CanCold cohort, and they compared the presence of disease and bronchodilator response in subjects with the lowest and the highest quartiles of airway to lung size ratio. Remember, the lowest quartile has the most dysynapsis. Subjects with the most dysynapsis had a COPD prevalence of 50% compared to 23% in those with the least amount of dysynapsis. Subjects with the most dysynapsis had an asthma prevalence of 66% compared to 22% in those with the least dysynapsis, and those with the most dysynapsis had a larger increase in FEV1 after bronchodilator. So in this case, in a patient who's never smoked and doesn't have typical asthma symptoms or risk factors, my feeling is that his spirometry probably doesn't indicate airways disease, but rather dysynapsis. It just takes longer for him to exhale his large vital capacity through normal size airways, and this will lower his FEV1 to FVC ratio. Of course, it would be wise to follow this patient over time to see if he does develop asthma later in life. Key points: pulmonary dysynapsis is a mismatch of airway to lung size. In some patients, dysynapsis may represent a normal variant, sometimes giving the appearance of airways disease. However, dysynapsis does appear to increase the risk of asthma and COPD, possibly due to abnormal lung growth before reaching adulthood. Thank you for watching PFT Tutor with Jeffrey Haynes. Please click the like, subscribe, and notification buttons, and we'll see you next time.